Hello, everyone, and welcome to today's webinar, COVID-19 in Florida. What are we doing to effectively leverage health IT? My name is Ivy, and I'll be your moderator today. I'm a member of the South Florida HIMSS Chapter Advocacy Committee, and I'm excited to be hosting this session. I'd like to introduce Ms. Kendall Brown, President-elect of the South Florida HIMSS Chapter, and the 2019 HIMSS Chapter Advocate of the Year, for a welcome message on behalf of the South Florida HIMSS Chapter.
Thank you, Ivy. Welcome, everyone. We appreciate your time and efforts today, and a special thanks to the panelists. We have an exciting topic to talk about. This webinar will be given by HIMSS National as well on July 30th. So this is the first of the two presentations we're giving. So if you missed something today, or if you want to see it again, you can see it. First of all, we are recording this session. You can find that on South Florida HIMSS website, but you can also attend the July 30th webinar as well. I also want to invite you to our next new member orientation on August 18th at 1:30 p.m. You can find those details on our website, southfloridahimss.org. Vanessa, if you could go to the next slide for us. Special thanks to our sponsors for South Florida HIMSS, and Nutanix, KPMG, and Dell. And if you're looking to become a member, you can go to our website and find out information. You can reach out to myself or any of the board for sponsorship information, or if you're already a member and looking to get more involved in the chapter, there's many ways to get involved, and I'm happy to speak with you about the different areas. So please reach out to any of us. Thank you for your time today. Thank you to our panelists, and I'll turn it back to Ivy to start the program.
Thank you, Kendall. I am not sure what happened, but I just lost my camera. But we'll proceed without it. So we are thrilled to have as panelists 5 experts on our state health IT infrastructure and policy to teach us about the health IT platforms and tools that are available in the state of Florida to perform syndromic surveillance activities. First up, we have Mr. David Brown, who is also our Advocacy Committee Chair for the South Florida HIMSS Chapter and partner of Maury, Rollins, and Brown. We also have joining us Ms. Pamela King, Outreach Coordinator for the Florida Health Information Exchange, and Mr. Aaron Parsons, Senior Manager of Audacious Inquiry. From the Department of Health, we have Ms. Allison Culpepper, and she is the Enterprise Manager for the Florida Department of Health. We also have Ms. Virginia Warren, Electronic Case Reporting Informatician for the Florida Department of Health. And rounding out our speakers, we have Mr. Eduardo Gonzalez Lumet. He is the CEO for Rubos and the manager of the AIMS platform. So as you're probably aware, public and private organizations across the nation have implemented numerous initiatives to collect a vast array of health data. This data is used to perform a variety of activities, which include monitoring and dissemination of information. And these activities can range from anything as small as seasonal monitoring of the flu, to much less publicized efforts such as monitoring for bioterrorism. So today we're going to be exploring how states such as Florida leverage health information technology to collect and share information related to surveillance activities. The goal of today's session is really to provide our participants with an understanding of the why these programs exist, the who is responsible for the data collection and analysis, and the how this all comes together to keep our communities, healthcare workers, and most vulnerable safe. Before we get started, I do have a few housekeeping items to cover. First, today's webinar, as Kendall had mentioned, will be available on demand after the live session, and it'll be accessible through the South Florida HIMSS Chapter website. Next, we'd love to hear from you during today's presentation, so if you have a question for our speakers, please feel free to send it through the chat function. Now, we recognize that there may be a lot of questions related to information in the media, but our focus today is exclusively an educational one, and our panelists are not prepared to address these questions. We'll be answering questions at the end of the session, so if we don't get to your question during today's webinar, we'll be sure to follow up afterwards. And the very last item is I'd like you to encourage you to share today's webinar with your social networks. We had incredible response for today's webinar, and we did max out our registrations. So we'd love for people, that are interested in learning more about these topics to go to our website and see the presentation on their own. So David, without further ado, I'd like to kick things off by welcoming Mr. David Brown, who will be speaking on the rules and regulations that establish the collection and reporting guidelines for diseases of public significance in Florida. David, the floor is yours.
Thank you, Ivy. To start today's discussion, I thought we would begin with a couple questions. How does the legislature in the state of Florida have anything to do with leveraging health IT? I think everyone recognizes that health IT has everything to do with data. And in this case, the state is very interested in being able to analyze that data in order to make informed decisions. The next question you might ask is, by what authority does the state have to collect anyone's healthcare data, and what data can they collect? My purpose on the panel today is to address these questions and hopefully clarify any additional curiosities you might have around this topic. To answer these questions, we have to look no further than the hierarchy of law. In this case, it all emanates from Title 29 of the Florida statutes. Title 29 addresses public health in a general sense and is made up of specific chapters of law. As an example, Chapter 3801 of the statute, 381.01 of the statute creates the public health system in the state of Florida. Chapter 381-001 identifies the duties and powers of the Department of Health, and Chapter 381.002 identifies the Department of Health's authority. There are many other chapters in Title 29 that address multiple and specific public health issues. Title 29 and specific chapters of law and how and what they work might be the next question you would ask. Where does COVID-19 fit into this mix, since it is a new virus or condition and is related to the issue of data collection based on a virus, which falls under Chapter 381.0031, which addresses epidemiologic research. This chapter outlines the authority of the Department of Health through epidemiologic research, a requirement that health providers notify the Department of Health of diseases or conditions of public health significance. The way that the healthcare providers would notify and validate the existence of a disease or condition would be through the collection of data, in this case, lab data that shows the presence or absence of a virus. However, in passing this chapter law, the legislature does not delve into the specifics of what diseases or conditions would be a public health significance, or what data should be provided to the Department of Health. Although we are obviously aware of many of diseases or conditions that have occurred in the past, some of the examples would be the hepatitis B outbreak this past summer, seasonal flu, the Zika virus, etc. So how could the legislature possibly identify every circumstance that might impact every health condition where the Department of Health would need to get involved? The way the legislature addresses this is by requiring that all agencies or an agency develop rules that will offer this more specific direction. These rules can be found and are addressed in the Florida Administrative Code, in this case, Chapter 64D3. Within this chapter of Administrative Code, the agency has created a table of reportable diseases and conditions, and further defines who a healthcare provider is. And it's not just physicians and hospitals. Coronavirus does appear on this list as it has been a known disease, so healthcare organizations are required to report this information to DOH. However, COVID-19 is not specifically listed, and in order to clarify the reporting on this specific virus, the Surgeon General issued an emergency rule, 64 DER 20-18, parentheses 64D 3.029. requiring the immediate reporting of all suspected or confirmed cases of COVID-19, and it is worth noting the emergency rule specifically requires both positive and negative test results including antibody testing, to be reported by physicians, hospitals, and laboratories. The Surgeon General's authority to issue this emergency rule came from the Governor's Executive Order 20-52, which was issued on March 9th, again, specifically addressing the COVID-19 pandemic. So to summarize, the hierarchy of law that gives the state of Florida the authority to collect this data began with the creation of Title 29 in the Florida statutes, the various chapters of law that creates the public health system and the creation of the Department of Health, and the duties, powers, and authority further clarified. The rules agencies developed within the Florida Administrative Code to further define what agencies can or should do. And in the case of extenuating circumstances like coronavirus, executive orders to the governor to further direct agencies to address these extenuating circumstances. Emergency rules by the agency heads to specify requirements that will address the executive orders and the rules and the chapters of law has been previously approved. So the emergency rule can only be put into place if all of the other requirements have been met. This is how the state of Florida has the authority to leverage health IT in order to more effectively address COVID-19. I hope this addresses any concerns you might have regarding why and how the state is able to require healthcare organizations to collect, share, and analyze lab data for the benefit of all constituents. And with that, I'll turn it back over to Ivy, who will introduce our next panelist. Ivy?
Thank you. Thank you, David, for that comprehensive introduction into the regulatory drivers for collecting healthcare data. So next, we're going to transition to an orientation on the health IT platforms that are available in Florida and how data flows through them to the different participating entities. So this section is going to be divided into 3 segments. For the first segment, we have representatives from the Florida Health Information Exchange, Ms. Pamela King and Mr. Aaron Parsons. They're going to discuss 2 platforms. They're going to discuss PULSE, which is short for the Patient Unified Lookup System for Emergencies, and the Encounter Notification Service, commonly known as ENS, and their applications during the COVID crisis. The learner objectives that they have set out to meet are how to collaborate with healthcare providers, health plans, ACOs, and other organizations during health emergencies and for everyday care. They're also going to talk a little about promoting patient engagement and better health facility utilization through the use of data available from local, state, and national entities. So Pam and Aaron, take it away.
Well, thank you, Ivy, and thank you again, David, for that legislative review on the requirements around providing information for the purpose of public health research and investigation. We, by which I mean Aaron, is going to be providing a lot more information on opportunities, and I stress opportunities because this isn't mandatory for healthcare providers to participate in the Florida Health Information Exchange. Participating in the Florida Health Information Exchange allows important data to be transmitted between healthcare entities that share responsibilities for patients, including the Department of Health. And there are several services that the Florida HIE supports for public health emergencies. But today, Aaron, who is a manager with our Florida HIE vendor, Audacious Inquiry, is going to share a little bit more information on two of these services, and Ivy highlighted those. So he's going to get into the details about how those services work. I say details, really kind of high level about how those services work and the benefits of those services during this time. So Aaron, I'm turning it over to you.
All right, terrific. Thank you, Pam. Can you hear me okay?
Yes.
Okay, great. Well, thank you, Pam, and thank you, Ivy, and thank you everyone who's joined us on the line this afternoon. So I'd like to start by sharing some basic information about our Patient Unified Lookup System for Emergencies, or PULSE. PULSE is an easy-to-use web platform that facilitates health information exchange during declared disasters. It allows authorized users to view clinical documents that include information about a patient's medications, allergies, diagnoses, lab results. PULSE is intended for use by clinical providers in alternate care sites and public health authorities. So to elaborate on that a little bit, an alternate care site might be set up after a hurricane to augment local hospital capacity. And Pulse would allow the doctors and nurses in that alternate care site to access a patient's records from nearby hospitals and clinics. That allows them to provide more informed care to the patients who are sitting in front of them. For example, avoiding medication interactions or allergies. Epidemiologists could also use Pulse to electronically retrieve records on reportable diseases, allowing a better understanding of threats to public health. So Pulse was developed by Audacious Inquiry in 2014 and 2015 with funding that was provided through the Office of the National Coordinator for Health IT, or ONC, for use in California. So this version of Pulse was deployed during the 2017, 2018, and 2019 California wildfires to assist with the response. And in 2018, we established a partnership with the Sequoia Project to provide programmatic support for Pulse deployments around the country. And later this summer, Pulse Enterprise will be released, which includes additional functionality and is built for nationwide scalability.
And I'm going to jump in here real quick, Aaron. I don't want people to get confused about us talking around events that have happened in California. Audacious Inquiry does a lot of work nationally. They are the vendor, as I mentioned, for the Florida Health Information Exchange Services, and we are working with them to enable Pulse connectivity here in Florida. We're actually working with the Sequoia Network, who oversees this service now, to enable Pulse here in Florida.
Great, thanks, Pam. And how does it work? So Pulse works by enabling end user access to existing interoperability initiatives. So we're not reinventing the wheel. We're not building connections where they already exist. Instead, we're tapping into connections that exist as part of the eHealth Exchange and as part of care equality. So large numbers of hospitals, and it's detailed on the slides there. Hospitals, provider groups, regional and state health information exchanges, dialysis centers, federal agencies, a large variety of organizations already participate in either the eHealth Exchange or care equality. And Pulse works by giving its authorized users access to the clinical records of other participants, of other organizations, only during declared disasters. And by building on the existing connections, Pulse is positioned to help states better respond when disaster does strike. So that was the first platform. I want to spend just a few moments talking about our Encounter Notification Service, the other health IT platform that we operate with the state of Florida. ENS provides real-time notice of patient healthcare encounters. This allows primary care physicians, accountable care organizations, health systems, payers, and others to know when their patient or their member receives care at a connected facility. The network currently covers 95% of acute care hospitals in Florida, 89% of inpatient rehab hospitals, and a smaller but growing number of skilled nursing facilities, and that's at about 20% right now. So anytime a member or patient is seen at one of these connected facilities, we'll alert their PCP, their ACO, their payer about the encounter. And those alerts allow care coordinators, case managers, other folks that are on those teams to better engage with the patient and with the treating facility on transitions of care from acute to post-acute or home. And it also enables post-acute follow-up that results in fewer readmissions and improved patient outcomes.
And this is the ENS flagship service of the HIE. And so I know a lot of reading in it. I have a little bit of liberation, so I'm going to stop talking.
Looking at the folks we have on the line, there's a number of folks who are part of this network on the line here this afternoon. These folks and others who are part of ENS can access alerts on their in a couple of different ways. But we can deliver the data securely in a couple of different ways. We can also customize the data feed to alert on specific conditions like coronavirus, influenza, behavioral health conditions, anything that can be listed in the diagnosis code field in the hospital data or other facility data that we receive. So for example, we have a large number of participants who are currently right now using Prompt to proactively identify their COVID positive members. And that allows them to better engage with those patients and to assist them with receiving appropriate follow-up care. We also, as I mentioned, have a number of skilled nursing facilities connected. It's about 150 right now, or about 20% of our statewide total. And participation benefits SNFs and their patients in a number of ways. It alerts the patient's PCP, ACO, or payer of their admit to and discharge from the facility. It also notifies the skilled nursing facility when they admit the patient of known affiliations that the patient has with payers or ACOs. And that helps the facility to both improve care coordination with entities outside of the facility that are involved in the patient's care, and also to meet their contractual obligations for members. The network also notifies the SNF when a recently discharged patient returns to the hospital. And that's particularly valuable right now with respect to COVID, as it can allow the facility to take appropriate steps to remediate the spread within their facility. So we're alerting them, this patient that you discharged a week ago has now shown up at the hospital as a coronavirus patient. So that's assisting skilled nursing facilities in better managing that risk as well. And ENS also supports the Florida Department of Health syndromic surveillance activities, which I know our friends at DOH are going to get into in a bit more detail here shortly. The DOH Essence biosurveillance system provides epidemiologists with the data sources and the tools that they need to identify outbreaks and unusual trends more rapidly, which leads to a more timely public health response. The Essence platform already receives data from hospital emergency departments all around the state, but it has limited inpatient data. And so we worked with DOH back in 2019, good timing before the pandemic hit, to enable a feed of a limited truncated set of data around inpatient encounters that enables enhanced syndromic surveillance capabilities by the Florida Department of Health. And so we're excited to be involved with the state, with all these providers across the state in enabling data flows that assist them to better care for their patients. And we're just excited to be able to offer systems like Pulse and ENS that public health needs and help deliver better care for all Floridians. So yeah, thanks again, folks, for listening and for your time. And Ivy, I'll turn it back over to you.
Thank you, Pam and Aaron. Really, it was a great orientation and really all the hard work that you do, just making sure we're able to share data across the state. Now that hurricane season is colliding with COVID-19, there's definitely an added incentive to ensure information is reaching the right sources in a timely manner. We actually have a named storm soon to become a hurricane, I believe, today. So we look forward to seeing more about Pulse. So we do encourage today's participants to reach out to the Florida Health Information Exchange for more information on how they can participate in either of these programs that were presented. So we're going to move on to our next segment, which will be presented by representatives from the Florida Department of Health. Allison Culpepper is our enterprise data manager from the Department of Health, and Allison's team facilitates electronic data exchange, integration, and file movement between external trading partners and the department, and she's going to be speaking a little about that. And we also have Virginia Warren, who is the electronic case reporting informatician, and she's responsible for facility onboarding and data validation. So looking forward to what they have to present. Allison, Virginia, take it away.
Thank you so much, Ivy. My name is Allison Culpepper, and I work here at the Florida Department of Health as the Enterprise Data Manager. So essentially, my team works on bringing data from external entities into the Florida Department of Health for various program areas. As you can imagine, our big initiative right now is getting all COVID-19 laboratory results into the Florida Department of Health, and we have been swamped the last few months, and it seems like there is no end in sight. So I am going to start by talking a little bit about laboratory reporting, followed by syndromic surveillance, and then get a little bit into our data modernization initiatives here at the Florida Department of Health. As mentioned earlier, all practitioners, hospitals, and labs are required to notify the Florida Department of Health of diseases and conditions of public health significance under Section 381.0031 of Florida Statute and 64D3 of Florida Administrative Code. Hospitals and providers are required to notify the department of diseases or conditions and their associated laboratory test result listed in our table of reportable diseases and conditions to be reported, which is listed on our Department of Health webpage. One thing you may be wondering is if coronavirus was listed on our table of reportable diseases. And it was listed. We did have coronavirus associated with severe acute respiratory disease listed in our table of reportable diseases. However, we did send out an emergency rule and an emergency guidance to all healthcare providers clarifying that COVID-19 does fall under a coronavirus associated with severe acute respiratory disease, and we do need those positive and negative results. Public health depends on the notification of these diseases and conditions of public health significance to monitor the health of the community, guide preventive action, implement timely disease and outbreak control measures, and provide information for situational awareness to support decision-making during public health emergency responses such as the COVID-19 pandemic. So I'm going to really dive into laboratory result reporting for COVID-19. And I wanted to tell you guys about how exactly we're getting those results into the Florida Department of Health. So we have two sources of data. One is called electronic laboratory reporting, which is being initiated throughout all public health agencies across the country, as well as antiquated, faxed, paper-based reporting. So as you can imagine, we really push for electronic laboratory reporting from facilities as much as we can because it's automated, timelier, the data is cleaner, and it goes right into our system. For paper reporting, it's very difficult for labs to identify which results need to be reported. Paper reporting consumes a lot of human resources for not only the healthcare providers, but also public health. And it results in delayed detection and response to acute, chronic, and emerging public health threats. So essentially, if a facility is sending us a paper result by fax, we have to have staff here at the Florida Department of Health manually enter each laboratory result into our surveillance system, which, as you can imagine, with the number of testing that's occurring, can take a significant amount of time. ELR automates the reporting process and alleviates this challenge while improving the timeliness and completeness of reports. Studies show that ELR supports public health decision-making approximately 5 days faster than if results were received on paper. Additionally, ELR is incentivized by the Meaningful Use, or now called Promoting Interoperability program, which has caused more hospitals to start engaging with public health to send ELR results to us. Now, as you can imagine, we haven't even really needed meaningful use throughout this COVID pandemic because of the sheer volume of COVID results that need to be reported to us. Everyone wants to send electronically, and we absolutely encourage it. Sending electronically not only helps, again, the provider, but it also helps public health. So really, coronavirus in and of itself has been a huge incentive for us to get people onboarded with ELR. Some of the data elements that are captured for electronic laboratory reporting include, specifically for COVID-19, include patient demographic and identifiers, test information, result information, facility and provider information, and then dates around when the specimen was collected and received. To go back on that patient demographic information, some of those fields are obviously patient first and last name, patient address, patient city, state, zip, so on and so forth. One thing that we are requesting, and Health and Human Services recently sent out guidance about this to really encourage facilities to report, is the race and ethnicity values. National averages show that approximately 85% of our ELR and paper reports are missing race and ethnicity. Having race and ethnicity fields allow us to understand the distribution of illness and if control interventions are working. So it's really important for facilities to send that demographic information, and that's why it's used. The same with patient address. Patient address allows us to determine which county a case is associated with. So if we don't have patient address in an ELR or paper result, we don't know what county to associate a case with without further investigating with the provider. Additionally, patient address allows public health to display and determine where the hotspots are during the COVID-19 pandemic. We also request patient phone numbers so we can follow up with the patient. Without patient phone number, we cannot immediately contact the patient when we receive a case. We have to call the doctor's office, try to get the patient's phone number, and really chase down that information. So those are some of the data elements that we receive for COVID-19 and we request from all facilities. In addition to the positive and negative results, we also require the antibody results, antigen, PCR, any and every COVID-19 testing that occurs. The method of transport currently for COVID-19 electronic laboratory reporting is something called Secured File Transfer Protocol, or better known as SFTP. For COVID-19 reporting, the department accepts data either in an alternate file format, which is also known as a CSV or a pipe delimited file, or an HL7 format, which is health level 7. HL7 is obviously the preferred method of transport, and it requires national standardized national standardized data as well as LINC and SNOMED codes associated with the test. For the timeliness, we require all facilities to submit their results minimally once a day, but we encourage near real time or as real time as possible. The Florida Department of Health has a data integration team that acts on the source data provided and delivered through the FTP account, performs data mapping and translation on the data, and moves the data to a defined destination to achieve the department in program areas objective. So specifically for COVID-19, our data integration team takes the data, delivers it to an FTP account, parses and cleans it up if it's messy, and ensures that it's structured correctly so that it can be properly consumed into our reportable disease surveillance system, which is Essence, Florida, and Merlin. Some of the data sources that we receive for electronic laboratory reporting are our interstate feeds through the AIMSS platform, which are essentially state-to-state feeds. So if a patient is in a state that is connected with us, but they reside in Florida, that state public health agency can submit those results to us in real time through the AIMSS platform. We're currently in production with Tennessee, Alabama, New York, U.S. Virgin Islands, and New Jersey. We also have a connection with Quest through the AIMSS platform, which actually accounts for over 54% of our COVID results to date. So we are really thankful to have that, that great connection with Quest. We have ELR connections with our public health laboratories, hospitals, urgent care centers, and recently, we've really started expanding to doctors' offices and private practices, football stadiums who are doing the drive-through testing, pharmacies, plastic surgeons, dermatologists, and even Amazon. We also have a feed established through the AIMSS platform to send all of our COVID-19 results to the CDC and ultimately to Health and Human Services. In 2013, we had 5 million results, and since then we've grown to over 75 million in 2019. So I anticipate that in 2020, by the end of the year, that number will probably be tripled. I want to talk a little bit about our syndromic surveillance system, which Erin mentioned. Our syndromic surveillance system has really been used nationally throughout the COVID-19 response, and it provides near real-time data for hospital, emergency department, and urgent care center visits for detection and monitoring of detection and continuous monitoring of public health threats. We have 99% coverage of our hospitals using our syndromic surveillance system, and 2/3 of them submit in real time. We also have several data sources for our Essence Florida syndromic system, which is EMS ambulance data, Office of Vital Statistics death record data, hospital inpatient data from our partners at ACA, our Merlin reportable disease data, STD data, and DMAT data whenever there's an emergency event that occurs. Now I'm going to talk a little bit about our data modernization initiative. With a population of 21 million residents, Florida is the 3rd most populous state in the country. And in 2019 alone, we had 112.8 million tourists. Because of that, the burden on public health resources continues to grow. Unfortunately, manual paper reporting continues, which results in delayed detection and response to public health threats. Our large population and healthcare transformation demonstrate growing pressures on our public health information systems and the need to operate efficiently to support timely data collection and analysis. One of our data modernization initiatives that we're partnering with the CDC on, which is really a national initiative, is something called the Public Health Data Modernization, and it's really trying to build a high-speed data superhighway to keep us safe from diseases and outbreaks. So our 4 modernization initiatives here in Florida is electronic case reporting, really expanding out our state-to-state connections through the AIMSS platform, focusing more on interoperability and making systems speak to one another, and then enhancing our public health lab capacity with newborn screening and electronic test ordering and resulting. Virginia Warren is going to tell you next a little bit about electronic case reporting and how it ties into the COVID-19 response. And we're really excited about it. It's really the future of health IT for public health, and we're already making a lot of progress on it. So Virginia, I will let you take over.
Hi everyone. As Ali mentioned, my name's Virginia, and I work for the Florida Department of Health as the electronic case reporting informatician. And today I'm going to be talking about electronic case reporting. And really my goal is to make sure that you understand what electronic case reporting is and why it's important. So first, we'll start off addressing the question, what is it? And I wanted to make sure you had the official definition, so I've got it here to read it to you. The case reporting, electronic case reporting, is the automated generation and transmission of case reports from electronic health records to public health agencies for review and action. So that's the official definition. And to bring it to life to you today, I'd like to connect this discussion about electronic case reporting to some points that have already been established today. Next slide, please. So one point that's been well established, I think, is that by law in Florida, laboratories and healthcare providers have to report certain conditions of public health concern to the Florida Department of Health. Next slide. Another point that has been established is that laboratories have a way of making their reports electronically via that system called the Electronic Laboratory Reporting System, or ELR.
It looks like Virginia's lost communication. Virginia? Allison, would you be able to speak to the rest of Virginia's slides until she's able to reconnect?
Sure, absolutely. So next slide. And you go to the next slide. I'll just go through, keep going, because I wasn't sure exactly what she had for these. You keep going. Okay, so as Virginia was mentioning, electronic case reporting is essentially like plugging in a hospital EHR to public health. All of this occurs through a centralized hub called the AIMSS platform, which Eddie will talk to you about briefly. But essentially, the provider connects to the AIMSS platform, and there's a repository called the Reportable Condition Knowledge Management System that applies reportable disease case reporting rules. And if one of the patients that is connected to RCKMS through the provider meets that criteria, then a case report is triggered to public health, which is essentially an electronic initial case report. If an electronic initial case report is delivered to the public health agency, then a reportability response message is delivered to the provider. So really that just means that everything is automated completely on the back end. The provider really doesn't have to do anything, and they'll also essentially receive a receipt saying, hey, this met the criteria for a case report to the Florida Department of Health. We sent this message for you, and there's nothing else that you have to do. Next slide. So this is an example of an electronic initial case report. So as you can see, essentially case reporting digitizes the entire medical record. Right now, what we really only have ramped up is electronic laboratory reporting, which is just getting that lab result electronically. And electronic case reporting digitizes the entire medical record or case report. So we're getting it all electronically, and we're not having to still get that paper case report from the hospital. These are some of the data elements that we get in an initial public health case report, such as demographic information, which is naturally much richer than what we see by paper and ELR. Encounter notifications or encounter information, the patient's medication history, all of the patient's lab results, all of the patient's immunization records, their comorbidities or their history of present illnesses or previous diagnosis, their reason for visits, and their current problems. So it really helps us to paint the full picture of what's going on with a particular case, which we're learning to be very important for the COVID-19 response. This is an example of a reportability response message. And again, as I mentioned, this is essentially like a receipt that's delivered to the provider. And it basically says, this patient met the criteria for an electronic case report to the Department of Health, and this is why. And this has been delivered through the AIMSS platform. Next slide. And this is just a slide. Yes.
This is Virginia. I just wanted to let you guys know, I'm so sorry. A lightning bolt knocked all my electricity out, and I'm connected via my mobile phone right now, but you're doing a great job. But I just wanted you to know that I'm here in case you would like to hand it back.
Sure, you can go ahead.
Okay. So, so far, I imagine you guys have covered what electronic case reporting is, and now you're getting more into the process-oriented explanation of it. And the reason that I had built this slide into the presentation was not specifically to go over all the elements of it, but because I wanted to emphasize trigger codes. Trigger codes are the criteria provided to healthcare providers by public health that consists of LOINC, ICD-10, and SNOMED codes. And when they are matched, these codes trigger the generation and transmission of the initial electronic case report that Allie went over with you guys to the AIMSS platform. Next slide, please. So the AIMSS platform is an informatics messaging service that's governed by the Association of Public Health Laboratories, and it houses a component of the electronic case reporting system called RCKMS, which stands for the Reportable Conditions Knowledge Management System. And RCKMS is really a decision support tool. It goes through the data that is that makes up the electronic initial case report, and it verifies that the condition submitted is reportable, and then it figures out which jurisdiction to send it to. So Hillsborough County, Pinellas County, maybe it needs to go to another state. Next slide, please. So hopefully by this point in the presentation, the goal was for you guys to understand what electronic case reporting is. And from my perspective, it's really a streamlining of the traditional case reporting process. And it's the process by which messages about reportable conditions flow between healthcare providers and public health by health information technology. So another key thing that I wanted to get across today is, why is electronic case reporting important? And I'd like to address this from both the perspective of the healthcare provider and the public health professional. Next slide, please. From the healthcare provider's perspective, electronic case reporting is important because it supports the fulfillment of a legal obligation that they have without them thinking about it. It streamlines a traditionally onerous reporting process. It enables healthcare providers to get immediate feedback from public health, and it offers credit for promoting interoperability. Next slide, please. From the perspective of the public health professional, the people who process and investigate and respond to these reportable conditions are supported by ECR because it makes it possible for them to respond to diseases in a more rapid, efficient way. It enables better communication between healthcare providers and public health because it establishes a communication channel that did not exist prior to. It provides rich information for use in investigations, and it supports the generation of more accurate public health statistics that can be shared with the public and that can be used to inform policy and interventions. Next slide, please. So to make sure that the significance of electronic case reporting is clear, I'd like to now connect the concept with our response to the pandemic. So just for a moment, I'd like you to consider how electronic case reporting supports the pandemic response by allowing us to collect information that helps us understand which comorbidities to pay attention to, like diabetes or hypertension, what treatments are and are not effective, who should be isolated, and potentially vaccine effectiveness. So at this point in the presentation, we've talked about what electronic case reporting is, a streamlining of that traditional case reporting process for healthcare providers. We've talked about why it's important. Essentially, it makes us more effective and efficient. And the last thing I'd like to leave you with, next slide please, are some statistics to help you understand that electronic case reporting isn't just a vision, it's something that's in motion right now. There are 21 national reporting providers in production as of around July 1st. And there's almost 800,000 electronic initial case reports that have been delivered to 45 jurisdictions, and about 30,000 reportable electronic initial case reports have been delivered to the Florida Department of Health. So this is a really exciting initiative and one that's really going to push us forward. Thank you.
Thank you so much, Allison and Virginia. Definitely demonstrated your agility with all of our technical challenges. Great to see. So it's always really exciting to see how new data sharing initiatives that add value to the system and are actually measurable are just so helpful. And, you know, speaking to the ability to have actionable data 5 days sooner, as Allison was talking about through the electronic reporting, is certainly a big win. Anything that'll reduce the burden on providers to submit reporting is going to be a welcome relief for that overburdened workforce. So Virginia, certainly hope we're able to get a lot of people to embrace the electronic case reporting. I believe in Florida, there are a handful of organizations that recently piloted the electronic case reporting program with great success. Allison, could you briefly share how our participants can become active participants in that electronic case reporting program?
Yes, so we are currently live. We're partnering with the CDC right now during the pandemic to do what we call ECR Now, or rapid implementations of ECR. And we are currently live with Memorial Health System down in South Florida. They went live from start to finish in about a week and a half, which is incredible. And they actually became the second highest volume sender nationally in just 24 hours of going live. So we are really, really proud of Memorial Health System and Ganesh Prasad for being our leaders in that effort. We're also live now with Leon Medical Centers, Watson Clinic, and Premise Healthcare, and we have a number of hospitals that are queued up to begin the ECR Now initiative with the CDC.
Wonderful. Thank you, Allison. And a real shout out to Ganesh and team who are members of our South Florida HIMSS, and I believe Ganesh is also on our board. So Eddie, our final segment.
Yes.
Eddie, yes, sorry, and I know we're running down to the wire, and I hope we can get it done by 1. If not, if any of the audience can stay for a few minutes, that would be wonderful. So Eddie, I know you'll be sharing the technical aspects of the AIMS platform. AIMS is an acronym for the APHL Informatics Messaging Services Platform. I usually complain about acronyms, but this is a good one. So I will just let you take it away and see what we can get in. Thank you.
Thanks, Ivy. Thank you, Ivy. I appreciate it. We got about 8 minutes, so we'll rock and roll here. First, I want to thank the HIMSS South Florida chapter and Kendall and the board for the invitation. And I was looking at the participants, and we've got a lot of friends like George from Formedica, James from Infor, and I would be remiss to not recognize the Florida Department of Health. So our organization, our first customer back in 1999 was the Florida Department of Health to create an integration team. And the reason I bring that up is it's an amazing team, and Allie and Virginia are doing a great job. But a lot of the foundational components that we learned over the last 20 years in Florida, we've taken to a national level. As mentioned, I'm the CEO of Ruvos. We're headquartered in Tallahassee, Florida, with presence around the U.S. and in different parts of the world. And in partnership with the Association of Public Health Laboratories, around 12 years ago, we created a national hub, data exchange hub, which thankfully is in place and is heavily involved in COVID-19 activities, which you'll see soon. Next slide, please. So this is the definition, and the key word here is, this is actually cloud-based. So we moved the AIMS platform in 2013 to Amazon Web Services specifically, where we've got hundreds and hundreds of instances across the United States, facilitating data exchange for close to 20 different use cases. Our first use case was sending influenza data from the public health laboratories to the CDC. That was a success, and little by little, we've grown organically and been able to add different components like translation, transformation, and different services that you will see potentially like in a hospital, for example, right? So it's almost like a data integration center of competency at the national level. Next slide, please. When folks ask me, Eddie, what is this AIMS thing? It's really, at the end of the day, a community, right? It's just think of your community at home where you live, and it has infrastructure to every public health laboratory and agency across the U.S. There is, as you can imagine, a very robust security, Department of Defense level, and more security. When the APHL and CDC, as they support this great initiative, one of the key items is sustainability. We've experienced, as we all know, challenges around the United States when it comes to HIE, some very successful ones, like the one in Florida, and some not so successful. And one of the key factors is sustainability. So that's a key factor in the overall roadmap, not just technology, but how are we going to fund this thing? Training is extremely important. Naturally, being that bridge, that interoperability bridge between different transport mechanisms, between different EHR systems, is a layer that we introduced around 8 years ago, which has been great. And then partnerships and community. I mean, the reason we're on the phone, I mean, we're very grateful that we've got a great group of participants. The HIMSS South Florida chapter has created this forum for us to share our stories. So we're only as strong as naturally the community and the partnerships like the Florida Department of Health and some of the hospitals that are on board already. Next slide. So I mentioned that, you know, it's really got a national presence. You can go to the next slide and I'll continue with this conversation. We've got over 200 trading partners, so every state jurisdiction. That slide right there where it says 7 million messages flowing through the HIMSS platform on a monthly basis. Well, over the last 6 months, due to the obvious, that is up to about 40 million messages that are securely routed through the HIMSS platform. And when I talk to the technology folks on our team and I say 40 million, that's a lot. And they said, Eddie, remember that one message, let's say from a Quest, can actually have 10 children. It can populate this database, it can populate this dashboard, it can populate this portal. So really, it's more around 400 million potentially messages that are flowing securely through the HIMSS platform, which is very exciting. And we've had to expand and leverage the cloud computing elasticity to be able to support the surge of COVID-19. And we're in preparations to prepare, as we all know, for the inevitable, which is flu season in a few months. Next slide, please. So this is our ecosystem where we've got different layers of technology, very similar that you would see in a hospital, in a public health agency, just a little bit larger at the scale of the national level. I always tell people at the end of the day, it's really about the people, right? So the folks that are involved in the HIMSS platform are folks that have worked at public health agencies, have worked in hospitals, have worked at commercial laboratories, universities, and have brought different perspectives. And then, of course, the people that cooperate and work with us, getting that feedback from a hospital via the Electronic Case Reporting Initiative, or getting feedback from an Allison Culpepper or from folks from ACA, that's critical to really, continue strengthening this community endeavor. Next slide. Interoperability, quick example, US Air Force, US Navy, they needed to send influenza data to the CDC. The CDC uses something called FDOH. The US Navy and the Department of Defense could not install that. So the HIMSS platform came on board and provided that bridge, that interoperability layer. So at the end of the day, it's transport agnostic, always considering security. So we have many organizations that come to us and say, hey, I want to do SFTP, but the other organization wants to do direct secure messaging. Not a problem. The team, the technology can handle that interoperability. Next slide. Interpartner exchange. One of the things that we predicted 10 years ago was, as we get more trading partners on the platform, they're going to start wanting to exchange data with each other. For example, Florida exchanges data with ELR data with Georgia, with Alabama, with New York, which is really exciting. And you basically take an hour or two to make a few configuration changes, but the legwork and the foundations there, which has allowed for that cross-jurisdictional exchange. Vital statistics data, birth and death data, for example, is exchanged between jurisdictions, getting rid of that paper process, or actually creating data transport that was never there in the first place. Next slide. All right, so COVID-19, this is probably one of the more important slides here. We're heavily involved in COVID-19. Everything you see here is public information. So we are, there's a different instance of the HIMSS platform that is in a different team that is working on the Google Apple exposure notification system, which some public health agencies are looking to use. We are also hosting the SARA alert system focused on COVID-19 case management. So in addition to creating that infrastructure, that routing mechanism, we have the capability, and we currently host several platforms, third-party platforms of national significance. Next slide. All right, and right on time, Ivy, here's our contact information. I'm sorry if I spoke very fast. I'm a phone call or email away. Thank you very much, Ivy.
Thank you so much, Eddie, and I apologize that we had you run through, but I do want to thank all of our speakers for their time and really their dedication to helping educate us all about the health information technology that is available and its application in Florida. If you wanted more information or enroll in any of the programs presented, you can find our speakers' contacts information displayed on the screen. Again, unfortunately, we sort of ran out of time and won't be able to do our Q&A segment, but we did get some good questions, and I do want to thank all of the active participation from those submitting questions. What we will be doing is we'll be posting these questions and the responses on the South Florida HIMSS website along with this presentation. So thank you again for your interest. All feedback is welcome. We look forward to being able to do more sessions like this, and any of your suggestions will certainly be a valuable contribution. So thank you, everyone. Have a great day.